Hello, I'm Steven. I'm going to go over the BLS Science Summary Table and the 2025 updates that are regarding the aspect of BLS. So I'm going to try to do this quick nitty gritty, talk about the changes, and then talk about the important aspects to know how to do CPR and all the numbers. So that's the goal. Here I'm going to kind of put myself in a corner. There we go. Now I'm in the corner. Let me bring up the window here. So I'm talking about the sciences here. So the American Heart Association recently came out in October of 2025 with the new updated guidelines. So we're briefly going to view some of the algorithms as well as talk about them. But I do want to talk about first the changes. So a big change was the chain of survival. Uh, in the 2026 link was added to the adult and pediatric in-hospital cardiac arrest and out-of-hospital cardiac arrest chains. In 2025, they were fine-tuned to now offer a single chain of survival. Um, so that's its intention is to be applied to the adult and pediatric in and out of hospital cardiac arrest. So this single chain acknowledges that before cardiac arrest, prevention and preparedness can both be used to avoid and need to optimize resuscitation. So that's just something to think about when we are responding and caring for individuals that are victims of cardiac arrest. Another big change was infant chest compressions. So while the infant chest compressions in 2020, we were told to compress the sternum with two fingers, right? So two fingers on the chest, or the two thumbs applied on the nipple line for compressions. And then if you're not able to do that, use the heel of one hand. If you couldn't do this or this, you would do this then on the chest of the infant. Well, that was also fine-tuned in 2025, where the two-finger chest compression was removed, and that was due to the fact that rescuers weren't able to achieve that depth compression of 1/3 of the AP diameter, or approximately 1.5 inches. So now they're recommending that you're going to do compressions on the sternum with the heel of one hand, or the two thumbs encircling the chest as far as that goes. Now, the two thumbs encircling the chest is recommended for a two or more rescuer resuscitative effort. And a lot of times that if you can't do that, then revert to the one hand, the heel of the hand compression. In 2020, opioid-associated emergencies, there was a opioid-associated emergency algorithm, and that was in addition to the adult BLS algorithm. Now in 2025, it was acknowledged that since there is a opioid epidemic globally, essentially, and especially here in the United States, that they went away from that algorithm being separate and intertwined it with the adult BLS algorithm. So when we go through the BLS algorithm, we can see where it is inserted. Foreign body airway obstruction in 2020, it was 5 back slaps and 5 chest thrusts. So in 2025, what happened was they realized that the two finger on the chest doing the thrust was not enough depth to create enough pressure to try to expel the obstruction. So they went ahead and adjusted it to mimic what we're doing with CPR now. So it's either, it is the heel of one hand technique. So you're going to start with 5 back slaps or back blows, and then you're going to alternate supporting the head and neck with 5 chest thrusts, but the chest thrusts are now going to be the heel of your hand on the sternum. So that's the other big change there. Now the next two changes are affecting foreign body airway obstruction in children and adults. Now, with the children and the adults, it's very similar to what we did with the infants. What the difference being that in 2020 we only did abdominal thrusts for children and adults. Now in 2025 they realized that they're bringing it back. My understanding is about 15-20 years ago they went away from this, but I guess they have enough research saying that it's coming back. So in the current algorithm as of October 2025, we are looking at doing repeated cycles of 5 back blows, back slaps, alternating with 5 abdominal thrusts. So that's both for children and adults. And where we're doing it is 5 back blows is right between the shoulder blades. And then the abdominal thrust would be taking your hands, interlocking them, your thumb kind of in the umbilicus, and then doing that in an up motion to try to compress the diaphragm. You're going to do that until the object is expelled or the individual becomes unresponsive. Then they should be lowered to the ground, and emergency response should activate the emergency response system that much sooner. So those are the kind of the big things. Also in the BLS topics for pediatrics, we are looking to add, and they added opiate antagonists, naloxone, into the algorithm as well. So as what we see for the adults, it's being added to that BLS algorithm. It's also being added to the pediatric side of things. The other thing that they added some terminology. They changed some terminology, so fine-tuned it. It has to do with when do you use the child and infant CPR algorithm versus the adult. So the infant is now recognized as 1 month to 1 year. Then child is 1 year to signs of puberty, and signs of puberty on the boys, facial hair, armpit hair, chest hair, and then for the girls, chest, breast development, and things like that. Once that happens, then we're going to treat them as into the adult algorithm. So that's kind of the big changes in 2025. So let's kind of scoot up here to show you the algorithm. So you have the adult basic life support algorithm. So from here, we want to verify scene safety. Your safety is paramount. You have family, you have friends, kids, spouse, whatever the case may be, your safety is paramount. Please don't dart out in traffic. Please make sure you're aware of your surroundings. Any weird smells, odors, substances, any weird areas of the facility, electrical closets, electrical panels, random water or liquids that wouldn't normally be there, right? So just be aware of your situational awareness. Once we verify that scene is safe, we want to check for responsiveness. We are tapping and shouting. We're tapping fairly aggressively. We're shouting fairly loud, not only to see that responsiveness, if there is any, but that also helps perk up everybody's ears. In some of the facilities, there might not be people and a lot of traffic, so if you can be rather loud, it helps. Shout for help. We want to activate the emergency response system as soon as possible. Send someone to get an AED and or defibrillator. The American Heart Association also recommends combining those two things, and if possible, delegating individuals to get that. So it's not just somebody help me and somebody get an AED. It is you get an AED, you call 911. Once you are at that point where you're unresponsive, you've already activated emergency alert system, somebody's getting an AED, somebody's calling 911, or the rapid response number, or your facility, so understand where and how to activate that system, whether it's 9911, 7911, so on and so forth, or 5555. We're going to now assess them, meaning we're looking for breathing and a pulse at the same time. If they are breathing and have a pulse, great. Monitor until advanced care arrives. If there's abnormal breathing, gasping, agonal breathing, snoring respirations, whatever the case be, but it's abnormal breathing, but they have a pulse, whether it's weak or thready, it's one breath every 6 seconds. So whether it's mouth to mask, bag valve mask, one breath every 6 seconds. That also includes advanced airway. But with the advanced airway, it's with a pulse or without a pulse. So we're just going to do compressions at a rate of 100 to 120 compressions a minute. So just keep that in mind. If there's no breathing or there's only gasping, right, that agonal breathing, that's all a sign of cardiac arrest, and you don't feel a pulse, you want to start CPR. You want to start CPR quickly. You want to minimize interruptions. Push hard, push fast in the middle of the chest. 30 compressions to 2 breaths. Those breaths are delivered over 1 second each. You want to make sure that you are not over inflating and you're just giving enough breaths to see chest rise and fall. If there's an AED and or the AED arrives, you want to work around the compressor and apply those AED pads as soon as possible. A lot of times, depending on the team dynamic, sometimes the person that's been on the chest the longest would then pause, where the person that came with the AED will now restart compressions, and the person can now kind of take a quick breather, do 2 breaths, and or apply the pads. So it's just a team dynamic. My recommendation is start CPR when the AED arrives, let the person give them 2 breaths, and then switch. You apply the AED pads, and then have the AED turn it on, right? Step 1, turn it on. Step 2, follow the prompts. If there's a suspected opiate overdose, we want to get naloxone administered. If it doesn't delay CPR compressions, then go ahead and deliver it. A lot of them are mucosal atomizers now, so you just go ahead and spray that into their nose. The AED will do one of 2 things. It will check that rhythm, and then it'll check and analyze that rhythm, and then it'll find out, well, is it shockable or not shockable. So if it is shockable, give 1 shock, start CPR immediately after that shock. If it's not shockable, continue CPR. We want to make sure that we're on that chest as often as possible, minimizing interruptions to less than 10 seconds. Don't take the pads off. A lot of advanced life support will be able to adapt into those pads. So if it's a rapid response team, a code team, an ambulance, EMS, whoever shows up with their defibrillators, a lot of them have adapters that will do that. And or they'll just pull those pads off and apply their pads. So just something to think about when we're going through these algorithms. Now, the algorithm for pediatric advanced life support, pediatric basic life support is very similar to the adult. The differences are that if you are a single rescuer, it's 30 to 2, right? 30 compressions to 2 breaths. You're going to push hard, push fast. For your children, which is infants to puberty, it is going to be 1/3 the AP diameter, or approximately 2 inches. Approximately 2 inches. Now, if you find them, if the heart rate is less than 60 and there's signs of poor perfusion despite oxygenation and ventilation, then you're going to start CPR. So children have a low oxygen reserve, and a lot of times cardiac arrest is precipitated not by a sick heart, it's precipitated by a respiratory issue, whether it's a disease process, bronchiolitis, bronchitis, epiglottitis, croup, whatever the case may be. It's a lot of times it's an airway oxygenation respiration problem. So that's why we're looking to breathe 1 breath every 2 to 3 seconds if they have a pulse, and if they don't have a pulse, it's 30 to 2 as a single rescuer. If they're intubated, it's also 1 breath every 2 to 3 seconds. So this is the other thing. Is it a witness collapse? If it's a witness collapse, go ahead, activate the emergency response system and retrieve an AED. If it's not witnessed, you want to start CPR 30 to 2, and you want to then do that 5 times. After you do it 5 times or 2 minutes, go ahead, leave, and if you're by yourself, and then activate the emergency response system. The other thing to keep in mind is when a second rescue arrives, we're now changing it from 30 to 2 to 15 to 2. So 15 compressions, 2 breaths. So just something to consider when you are doing these scenarios and doing CPR. And then from there, it's the same idea. You apply the AED. You're going to turn it on, follow the prompts. From there, 1 shock, start CPR. If there's no shock, you continue CPR. With 2 or more rescuers on the pediatric basic life support, it's very similar. Okay. Also, going back to this one is if suspected opioid overdose, administer opioid antagonist. So just make sure that when in doubt, give them naloxone. Here is that repetitive cycle of CPR. So you find them unresponsive, activate the emergency alert system, and then start CPR. From there, apply AED, and we're going to push hard, push fast, and we're going to be very cyclical on that. Okay. Here's the foreign body airway obstruction for adults algorithm. I'm trying to center that for everyone. Verify that scene safety, check for signs, right? So we're looking for absence or weakness of cough, unable to speak, changes in colors, altered mental status, apnea, right? The idea is that it's not they can cough it, but if that's the case, don't leave them, right? Encourage them to cough. Continue to check for those signs of severe foreign body airway obstruction. I would also recommend ask them, hey, are you choking, right? So they're going to give you that universal sign, adults and children especially. If they are going to be drooling, there's a silent cough, they're changing colors, cyanosis around the mouth, whatever the case may be, then ask them, hey, do you need my help, right? So are you choking? Do you need my help, right? They're still awake, they're still alert, they're still conscious. We're looking for that consent. Now, if they say no, right, so at that point, don't leave them, but keep an eye on them and be in close proximity, because if it does turn into a complete or severe foreign body airway obstruction, then you need to act fast. I still would recommend activating the emergency response system regardless, especially if it's hard to tell if it's severe or not. I'd rather get them going as soon as possible. And then if they are responsive, start repeated cycles of the 5 back blows and the 5 abdominal thrusts. So something to consider also for patients that are in late stages of pregnancy, they're larger individuals, maybe they're in a wheelchair, put your hands through their armpits and around their chest, and then just compress back on their chest. For individuals that are in wheelchairs and things like that, just be mindful of the wheelchair and its features so you don't get pinned in there or they get pinned in there. Sometimes the chairs have multiple movements of freedoms where the back can recline or whatever the case may be. Just be aware of that. You're going to do that until the object is expelled or they become unresponsive. So if the object is expelled, monitor them. You never know, their airway could swell up, or they can start to choke again on something else or whatever the case may be and then become unresponsive. So just don't leave them alone. And if they do become unresponsive, lower them to the ground as gently as possible. Start with compressions, right? So push hard, push fast, right in the middle of the chest. Every time you go in for a breath, open their mouth, visualize the obstruction if possible. No blind finger sweeps, please. We don't want to push that deeper in if it's just right there, but if it is easy and it can come out, pull it out. And then try to give them breaths as easy as possible. Sometimes the obstruction is severe enough where it is complete, or not as severe where you can still give them a little bit of air and there's some oxygen exchange happening. So that's for the adult. For the child, it's very similar. You want to make sure that you're getting down to their level, not picking them up necessarily, but getting down to their level and doing the same thing, 5 back blows and 5 abdominal thrusts. So you want to start in that way, 5 back blows, 5 abdominal thrusts. With the infants, it is different, right? The infants, a little bit more portable. From the idea is you're going to start also with 5 back blows. So in all age groups, 5 back blows, adult, child, infant. What the difference is in the adult and child, it is abdominal thrusts. Please do not do abdominal thrusts on your infants. You want to do 5 chest thrusts. And those chest thrusts are being done with the one palm, one-handed method on the center of the chest. And same thing. You want to support the head and neck with your arm. You want to lower them kind of on a 45-degree angle where their belly, their butt is higher than their head, right? To let gravity help you when you're doing this. And then you just want to flip them kind of back and forth, face down and then face up, face down, face up, doing those back blows as well as those 5 chest thrusts. And same thing, they can become unresponsive and you want to start CPR as soon as possible. There is a BLS in pregnancy algorithm. So when you have cardiac arrest in pregnancy, the major takeaway from that is we want that manual lateral uterine displacement to the left. So that's very important when you're doing that. The left lateral displacement alleviates pressure on the inferior vena cava, increasing blood flow back to the heart. So that's just something important. I included this algorithm here to help with that, and it also talks about the explanations of cardiac arrest and the interventions within them. Something to also consider as far as advanced life support is get the appropriate teams involved, and we're looking at a perform resuscitative delivery within 5 minutes, depending on local resources. So keep that in the back of your mind of this if you're in a situation where it's CPR in pregnancy. I've also included here adult and pediatric durable LVAD algorithm. These individuals here in the larger metropolitan area, here in Chicago and other large metropolitan areas, LVADs are a thing. There's more LVADs now than there was 10 years ago, 20 years ago. So a lot of them, they're walking and talking and they are able to live a semi-normal life. One of the requirements is they have family with them that is trained on how to deal with their controllers and their drive lines, whatnot, depending on which LVAD they have. Now, these individuals will probably not have a pulse that is palpable. So we're talking about if you need to grab a blood pressure, things like that, you're going to need a Doppler. If they have adequate perfusion, so think of your signs of adequate perfusion, right? Cap refill that's within 2 seconds or less. They're not cyanotic, they're not in distress as far as that adequate perfusion category. Their limbs are not cool to the touch, right? If there's adequate perfusion, do not perform external compressions. We're assessing and treating non-LVAD causes of unresponsiveness. So it could be just as simple as a blood sugar. Could be as simple as they need fluids. The LVADs are a fluid-dependent pump, so maybe quite possibly they are hemodynamically unstable because they are fluid volume deficit. So something to consider. and then they are unresponsive for that fact. So they could be right at that level. Now, if they are not perfusing appropriately, whether it's signs of cyanosis, complete altered mental status, unresponsive, you can't feel a Doppler or hear a Doppler pulse, you don't hear on auscultation the pump running, the controller is not working right, whatever the case may be, perform those external chest compressions. It's okay. You want to assess that LVAD. You want to make sure that there's power, the battery is connected, plug it in, get a hold of their caregiver if they have any family around them or somebody that's familiar with the unit. Also calling their VAD center if possible, but also making sure that compressions are being done. Assess and treat non-LVAD causes for unresponsive. Once again, it could be just as simple as a sugar issue or electrolyte issue. So continue BLS, ALS, and then transport and contact that VAD center. Continue to monitor. Here's that summary table again. Helpful links. You can find more learning from the AHA at elearning.heart.org, accessing your e-cards at ecard.heart.org. Get ebooks, or if you've been issued previous ebooks or you want to get some ebooks, ebooks.heart.org to view their bookshelf. If you need any additional BLS, ACLS, PALS, or Stop to Bleed training, please don't hesitate. America Rescue can bring training to your site. I recommend getting a Metronome app if you have an iOS. I use this one here. If you have an Android, I believe it's the same application, but it is made for Android. I've also attached a chain of survival, recognition and emergency response being that first link. Towards the bottom of this, call 911, push hard, push fast. It could be as simple as that. Push hard, push fast. Check that scene safety. Remember, I want everybody to go home safe. Assess that patient, assess for responsiveness, tap and shout. Emergency alerts, activate the emergency response system. Delegate an AED, someone to get that AED. Delegate somebody to call 911 as at the same time. We're checking for pulses and breathing at the same time. We're trying to streamline it as best as possible. So we're doing those quickly, less than 10 seconds for both. If you find that this individual is not breathing and has no pulse, perform 5 sets of 30 compressions to 2 breaths. If you're a single rescuer, this is true for all age groups, 30 to 2, no matter who, if it's just you. Now, this is also the same for all age groups. 100 to 120 compressions per minute. Push hard, push fast in the middle of the chest. Now, for the adults, it's at least 2 inches. For the children, it's approximately 2 inches. And for the infants, it is approximately 1.5 inches. And all three, it's 1/3 that AP diameter. Provide breaths with enough force to produce chest rise. So 1 breath over 1 second each. So 30 to 2, so 30 compressions, 2 breaths. If you're working with bag valve mask, get that airway open, keep it open. It's a recommendation that is used with a 2 rescuer team. If it is a single rescuer, mouth to mask. And that's also for all the age groups. With the children, 15 to 2 if you have 2 rescuers. So 15 compressions, 2 breaths. Minimizing those interruptions to less than 10 seconds. For advanced airways, for the adults, it is 1 breath every 6 seconds. Or if they have a pulse but are not breathing, it's 1 breath every 6 seconds with a bag valve mask or mouth to mask. For the infants, with an advanced airway, it is 1 breath every 2 to 3 seconds. As well as rescue breathing, it's 1 breath every 2 to 3 seconds. When the AED becomes available, you want to make sure that you turn it on and then follow the prompts. Step 1, turn it on. Step 2, follow the prompts. Be aware, some AEDs are automated external defibrillators, right? And then now, more recently, it's automated external defibrillators. They are, if you will, set it and forget it. So you turn it on, follow the prompts. That is at least the same on all AEDs. The AEDs that are automatic, it'll tell you to either apply the pads and then plug in pads connector from their analyzing and shocking automatically, or on some pads they are automatically plugged in, you just have to apply them. But the important part is the AED will then analyze the rhythm. So you want to shout, do something about it, clear, right? Make sure we're not touching them. It'll analyze, and then it'll do a countdown. 3, 2, 1, shock delivered. So just be aware of the differences in your area. I recommend a little bit of homework. See where the nearest AED is around your workplace, around your home, where your shopping stores are, whatever the case may be, and see how long it takes you to walk there. So just a little bit of homework there. When the AED is brought back, and if the emergency alert system has not been activated, call 911 or your rapid response number, because some AED cabinets will not do that for you. So if you have any questions, please don't hesitate to ask, reach out. We'll get you the answers as quickly as possible. Thank you very much.